Let's learn the Renin Angiotensin Aldosterone System. I know most professors aren't really the best at teaching this, and comment below if you agree. But don't you worry, after this lesson, I can assure you that you will feel like you actually know it. Before we begin, we'd appreciate if you could subscribe to our channel by tapping below, as it proves to us that you guys want these lessons. Renin Angiotensin Aldosterone System, aka RAAS, is a super important system and has many functions in our body, but its principal function is to regulate our blood pressure. Let's think of it like this. We notice our blood pressure going down, perhaps due to a hemorrhage or bleeding. We're losing blood out of the body. Now the duty of the RAAS is to maintain blood volume and blood pressure. So how does it kick in, get activated, and begin regulating? Well, first, let's say our patient had a major car accident and began bleeding out. We draw his circulatory system over here, and then the organs which will play a role. The central nervous system, the brain and spinal cord, that will be responsible for the sympathetic outflow. Then we have the kidney, particularly the nephron. Next we have the liver and its role in the system, the pulmonary circulatory system, the lungs will draw over here, which is a major player. And finally the adrenal gland, particularly the adrenal cortex. More on this later. We'll go through all of these organs. So our patient is bleeding over here and the blood pressure is going down and the blood volume is also decreasing. So we can notice that the blood flow to the kidneys will decrease, meaning we have reduced renal perfusion. Anytime there's reduced renal perfusion, the veins from the kidney begin carrying an enzyme in the blood, released by the kidney, which travels to the circulatory system. This enzyme is one of the stars of the show, referred to as renin. Now blood pressure is going down and the kidney is producing more renin, and renin comes into the circulation. Now we have to see, by reducing the blood pressure, how does the kidney start producing renin? Well, for this we have to zoom into a nephron. Quickly, let's label the nephron. Here's the Bowman's capsule with the glomerulus, the proximal convoluted tubule, the loop of Henle, both a descending and ascending limb, the distal convoluted tubule here, and the collecting duct. Here we have the afferent arteriole, which is bringing the blood to the nephron, the glomerular capillaries, and the efferent arteriole. So, patient is bleeding, right? That means renal perfusion, as we said, is decreased, meaning the afferent arteriole also has a poor blood flow. Now the fascinating thing here is that in a nephron, there's a super cool device that measures blood pressure, built right into the nephron. Here, notice these smooth muscle cells that are on afferent arterioles, and as the afferent arteriole gets closer to the glomerulus, you see these altered smooth muscle cells here. These are actually a specialized group of smooth muscle cells on the wall of the afferent arteriole. This is your super cool blood pressure measuring device, the Baroreceptors. This group is called the Extraglomerular Mesangial cells, aka Pulcosyn cells, and are essentially modified afferent arterial smooth muscle cells, which are able to measure the blood flow to the nephron. Whenever there is less blood flow to the nephron, and these cells sense there's a decrease in blood pressure, they begin releasing renin into the blood. So these group of cool cells have two important functions. One is to measure the blood flow, and the second is to release renin. Normally what happens is when blood is moving through the glomerular capillaries, there's normally filtration happening, and the glomerular filtrate is moving this way. Now because the filtrate has a lot of sodium, the nephron cells take this sodium back inside the body. About 60% of the sodium in the filtrate, as it moves down the proximal convoluted tubule, is reabsorbed back into the body. The filtrate then keeps going through the nephron, and 25% of the sodium is then reabsorbed just before the bend, which is the end of the thick ascending loop of Henle and the beginning of the distal convoluted tubule. At this bend, there's about 10% of sodium left, and at this bend, the nephron cells are tall, they're darker, and modified. These cells love sodium, and are sodium-sensing cells, acting as chemoreceptors. These cells are called the macula densa. So as we said, these group of cells from before are a pressure sensing system, and these cells now are a sodium sensing system. Now both these systems create a whole apparatus. So we got one set acting as baroreceptors, sensing pressure from the afferent arteriole, and the other set of cells, Macula densa, as chemoreceptors sensing sodium from the distal convoluted tubule. Both these sets of cells are held together by connective tissue cells, and all these cells together are found in every nephron and referred to as the juxtaglomerular apparatus. So again, you know now the extraglomerular mesangial cells from the afferent arteriole are blood pressure sensing baroreceptors, and they meet up with the macula densa, the dark cells from the distal convoluted tubule, which are the sodium sensing chemoreceptors. Both these groups form the juxtaglomerular apparatus, which is an apparatus that is juxtaposed right by the glomerulus. You get it, right? So as we know, our patient is bleeding, the blood pressure is going down, blood flow is going down, and the renal perfusion is low. So when blood flow is down, baroreceptors in the juxtaglomerular apparatus are activated to release renin. Now, when blood flow is less through the afferent arteriole, it means that the glomerular filtration has to also be less. Less blood flow has to mean less filtration. Important to note here is that if there is less filtration, the filtrate moving through the lumen of the nephron is pretty slow. When the movement is slow, the cells of the nephron that grab things from the filtrate have more chance to work because essentially this flow is on a slower conveyor belt. These cells are happy and see it as an easier opportunity to grab more sodium from the filtrate off the conveyor belt of the nephron. So these cells of the nephron in the proximal convoluted tubule are extracting and reabsorbing extraordinary amounts of sodium. So very little amount of fluid reaches that bend of the distal convoluted tubule. The macula densa is upset. It loves tasting sodium, right? But now so much sodium from the normal amount has been reabsorbed before it even reaches the macula densa. Now the macula densa gets supercharged and active. It begins releasing nitric oxide and prostaglandins to activate the extraglomerular mesangial cells. It basically asks the baroreceptor portion of the juxtaglomerular apparatus to please listen. There's way too little sodium over here in the nephron. Something is definitely wrong with the GFR. Probably there is incorrect blood flow. So the extraglomerular mesangial cells start releasing renin to correct everything. So now you notice renin was released two ways, first from pressure change and now from the sodium change. But these two are the ways within the renal system. Let's see a third external way. When our blood pressure goes down, here from our heart we have the common carotid artery bifurcating into the external and the internal carotid arteries. Here we have the carotid sinus, which is another blood pressure measuring tool in our body, which is a baroreceptor. Patient is bleeding, so the blood pressure is low. The carotid system measures this and becomes activated. It sends a message via the glossopharyngeal nerve to report to the central nervous system that we have a fallen blood pressure. Once the CNS receives this message, it stimulates the vasomotor center in the medulla. Then fibers begin going down the column to stimulate sympathetic outflow. This results in preganglionic sympathetic neurons and the postganglionic neurons, which then travel their way to the juxtaglomerular apparatus. When the postganglionic neurons arrive at the apparatus, they release norepinephrine, and the extraglomerular mesangial cells of the apparatus have these beta-1 adrenergic receptors to bind the norepinephrine, and by being stimulated, these receptors release more renin. So to release renin, we have the afferent arterial cells measuring blood pressure, releasing renin, the cells from the distal convoluted tubule sensing our sodium, releasing renin, and lastly, these sympathetic fibers that are connected to the juxtaglomerular apparatus to stimulate the release of renin. So what does the renin do? Renin travels its way down the renal vein to the general systemic circulation. Okay, cool. But now there's another player, the big old liver. The liver is known to be a big producer of proteins, and in this system, it also produces a special protein called angiotensinogen. This protein is always being produced, so it's not just in a crisis like this one. Now, the enzyme renin that's circulating will work on the angiotensinogen and convert it into angiotensin 1. Now, when angiotensin 1 passes through the lungs, it is converted into angiotensin 2. What causes this change? Well, in the lungs, there's an enzyme called angiotensin converting enzyme. So now you're probably dying to know, where exactly do you find angiotensin converting enzymes in the lungs? Well, to be exact, they are found in the pulmonary capillaries' endothelial lining. Angiotensin converting enzymes here are responsible for converting angiotensin 1 to angiotensin 2. Now you already know that a lot of drugs target this enzyme to block its function and its action, the ACE inhibitors. But now you will know that there's another product hanging out in the blood called bradykinin. Now bradykinin is broken down by these enzymes and is therefore inactivated. Now interestingly enough, bradykinin is a vasodilator, and the ACE enzymes are vasoconstrictors. Now you must say that an ACE is a vasoconstrictor and a bradykinin vasodilator breaker. Why? Because as blood vessels constrict, the blood pressure will go up as we want it to. Now before we look at what angiotensin 2 will do, let's recap what we know so far. The patient is bleeding, renal perfusion therefore is reduced, the blood pressure sensitive cells releasing renin, the macula densa senses low sodium at the distal convoluted tubule, which is a sign of low GFR, which tells the cells to release more renin. We also have falling blood pressure sensed in our carotid system, which sends a sympathetic outflow that sends sympathetic fibers to the juxtaglomerular apparatus to release renin. Now the renin flows over to the general systemic circulation and breaks down the protein released by the liver, angiotensinogen, into angiotensin 1. When angiotensin 1 is passing through the pulmonary circulation, the angiotensin converting enzymes, which are present on the endothelial cells of the pulmonary capillaries, act on the angiotensin 1 to convert it into angiotensin 2, which is a powerful vasoconstrictor. While ACE is producing strong vasoconstrictors, ACE is also inactivating vasodilators like bradykinin. So remember, we need to bring up the blood pressure and the blood volume. We can now step into the world of angiotensin 2 and its function in the body. We'll first show here the left and right heart and the circulatory system, the arterioles from the aorta. Left heart has the blood that flows towards the venous system, and we already know that the blood comes from the arterial side through the capillary beds into the venous side to return back into the heart, and then gets oxygenated by the pulmonary circulation to get pumped back into circulation. Now, angiotensin 2 has its receptors on the arteriolar smooth muscles and on the venular smooth muscles. Angiotensin 2 will work on the venular smooth muscles by binding to its receptor so the veins constrict. When the veins are squeezed, the pressure begins to go up and the blood rushes to the right heart, which produces an increase in venous return. And then eventually this blood goes to the left heart. We can now say blood flow increases to the left heart. Increase in cardiac filling leads to an increased end diastolic volume and an increased end diastolic pressure, because at the end of diastole there is more volume and pressure. The ventricle is essentially stretched, and that's just because Frank-Starling said so. The more you stretch the ventricle, the more it contracts. Frank-Starling law states that if within physiological limit, the more you stretch the myocardial cells, the more they contract. So because of venoconstriction, the squeezing, increased cardiac filling, increased end diastolic volume, and increased end diastolic pressure. So at the end of diastole, more volume and pressure are in the ventricle. So more venous return, more end diastolic volume, we can say there is a more preload on the heart. So the more blood accumulation, the more it stretches and contracts, all of this will lead to an increase in stroke volume. As you already guessed it, an increase in stroke volume will be an increase in cardiac output. And an increased cardiac output will lead to an increase in systolic blood pressure. Our patient's blood pressure was falling, so with venoconstriction, there was an increase in venous return to the heart, and an increase in the end diastolic volume, and therefore increasing contractility and stroke volume, which results in increased cardiac output. And all of this resulted in our increase in systolic blood pressure. And please note that systolic blood pressure mainly depends on this cardiac output. Now, angiotensin II will work on the arteriolar smooth muscle, and the arterioles will constrict, with arterioles becoming more narrow, and during systole, lots of blood coming to the area just before the arterioles, the blood will not easily be able to pass to the venous side. And naturally, the heart will then be in diastole. The aortic valve is closed. Blood really can't go back anywhere. So normally the blood should easily pass through the capillary bed, but because of this constriction, blood will be retained on the arterial side, which means the pressure in the arterial tree will increase, giving us an increase in diastolic blood pressure. And guess what? We did it. We were losing blood, and blood volume and blood pressure were going down. So by venoconstriction and venous return, we increased the cardiac output and the systolic blood pressure. And by increasing the arteriolar constriction, we reduced the amount of blood from the arterial side to the venous side, which therefore increased the diastolic blood pressure. Awesome. But now angiotensin II has another path to go on, which is its effect on the adrenal gland and specifically the outer adrenal cortex layer called the zona glomerulosa. The cells in the zona glomerulosa also have receptors for angiotensin II. Now when the cells of the zona glomerulosa are activated by angiotensin II, they begin releasing substance called aldosterone. Aldosterone, another key player in the RAAS system, will work on principal cells, which are found at the end of the nephron, distal convoluted tubule, and the collecting duct, as you see here. The principal cell has a nucleus with genes. Aldosterone from the zona glomerulosa will go into circulation and reach the principal cell, and when it enters, it'll look for the aldosterone receptor. This receptor is a special protein key called an aldosterone-operated receptor, and when aldosterone binds, this complex will rush into the nucleus and turn and open the locks of the genes. When the first gene is open, it begins making a special protein that is actually planted on the basolateral membrane of the principal cell. And this is all because aldosterone binded. These proteins are super special because they are your favorite sodium-potassium pumps. You actually won't see them on the lumen side of the principal cell, but on the outer borders like we show here. And because of aldosterone, we have an increase in sodium-potassium pumps on these principal cells. The sodium-potassium pumps begin throwing out sodium from the principal cell into the interstitium, and at the same time accumulating potassium. So these cells become really poor in sodium and really rich in potassium under the authority of aldosterone. Okay, now aldosterone will also open the second gene, which will begin making another special protein that will actually be planted on the lumen side of the principal cell. These are your sodium channels. Channels just means the sodium will pass freely as wherever the sodium wants to go. Now the little sodium that is passing through the nephron, whatever little amount comes in contact near the sodium channels of the principal cell, the sodium will just rush in since it's from high concentration to this low concentration. And as sodium enters the principal cell, the sodium is pumped out to the blood. Now this is how sodium starts getting reabsorbed under the direction of aldosterone, and less sodium gets urinated out. And guess who loves hanging out with sodium? Water. So naturally, water follows and gets reabsorbed with sodium. And because the principal cell is so rich in potassium, the third gene is activated, which makes potassium channels on the luminal side. And because we have such a rich supply of potassium in the principal cell, the potassium will leak out to the lumen to be peed out. Now, this sodium and water that we reabsorbed into the blood circulation by using aldosterone, we definitely increase the blood volume, right? And because of an increase in blood volume, venous return will increase, ventricular filling will increase, contractility will increase, and so systolic blood pressure will increase. Great. But angiotensin has one more path to go on. It will travel to the central nervous system because it has receptors on the hypothalamus. And hypothalamus will send neurons to the posterior pituitary. And from the posterior pituitary, we'll have ADH. The ADH will act on the last part of the nephron and make it more permeable to water. The water that is moving its way out of the nephron will be pulled from the lumen through the cells into the interstitium. Because of this water reabsorption, water will not be lost into urine. And an increase in water in the blood, well, we already know. It will increase the blood volume, venous return, increase in ventricular filling, contractility, cardiac output, and of course, the systolic blood pressure. And that's all for the Renin Angiotensin Aldosterone System. Great job at keeping up with this lesson. Now take a second and comment a topic below that you'd like us to teach. We are listening. Credits and our inspiration for this lesson goes to the GOAT of professors, Dr. Najib. We thank you, sir, and with you, we will continue on the revolution of medical education. If you'd like to see more of this lesson, head over to our Instagram page and TikTok channel at rev.med. We'll have this lesson along with many other topics for you to study. By the way, don't forget to do questions. Are you learning something from our videos? Well then click the subscribe button to your right. We are releasing high-yield lessons and ways for you to get ahead in class. Be sure to follow us on Instagram to take interactive quizzes and view your favorite diagrams. Nothing can stop you, but only if you believe in yourself. You got this.